Good morning, everybody. I would like to welcome you to Immunic's Celiac Disease Research and Development webcast to discuss current pathways for drug development and persistent disease activity despite gluten-free diet as the unmet medical need. My name is Jessica Brew, Head of Investor Relations and Communications at Immunic. I will also be the moderator on today's webcast. As always, in the beginning of our webcast, I will walk you through a couple of organizational items first. Please note that all participants will be in listen-only mode, and this event is being recorded. During and after today's presentation, there will be an opportunity to ask questions. If you joined the webcast via the Zoom platform, there are two ways to submit questions. You can either submit your questions in writing via the Q&A tool of the Zoom portal, or if you would like to speak with us directly, please use the raise hand function in the Zoom portal to queue your question. Before we begin, I also would like to remind you that this presentation may contain forward-looking statements. Such statements can be identified by words such as may, will, expect, anticipate, estimate, or words with a similar meaning. And such statements involve a number of risks and uncertainties that could cause Immunic's actual results to differ materially from those discussed here. Please note that these forward-looking statements reflect Immunic's opinions only as of the date of this presentation, and it undertakes no obligation to revise or publicly release the result of any revision to these forward-looking statements in light of new information or future events. Please refer to Immunic's SEC filings for a more detailed description of the risk factors that may affect Immunic's results and these forward-looking statements. During the next approximately 2 hours, we will discuss the dynamics of celiac disease as a multifactorial complex autoimmune disease, immune stimulation and its connection to clinical symptoms, the role of the epithelial barrier in the pathogenesis of the disease, current and potential treatment option, and the continued unmet medical need for effective therapeutics. Most importantly, two renowned experts in the field, Dr. Joseph Murray and Dr. Michael Schumann, will discuss scientific and clinical aspects around celiac disease in more detail. Let me introduce today's speakers. We are very excited to have two renowned thought leaders in the area of celiac disease on our webcast today, and warmly welcome Dr. Joseph Murray from the Mayo Clinic in Rochester, Minnesota, and Dr. Michael Schumann from the Charité Berlin in Germany. Thank you to both experts for being with us today. From Immunic, speaking are Dr. Daniel Fitt, our Chief Executive Officer and President, Dr. Hella Kohlhoff, our Chief Scientific Officer, and Dr. Andreas Müller, our Chief Medical Officer. I'm very happy to hand over to Daniel now to start the presentation. Daniel, please go ahead.
Yeah, thank you, Jessica. I'm very excited that we got two outstanding experts to give us a first-hand insight in the role of the intestinal barrier function in GI diseases, and in particular understanding the challenges of celiac disease. Before handing over to our Chief Medical Officer, Andreas Müller, I would like to update you on Immunic's development pipeline. Recently, we have shown very exciting data generated in the so-called Emphasis clinical phase 2 trial in RMS patients. In this trial, RMS patients were treated with vidofludimus calcium or placebo. In November, we reported that patients receiving vidofludimus calcium had a much lower rate of 12-week and 24-week confirmed disability worsening compared with the placebo-treated patients. The activity of vidofludimus calcium is now being tested in two pivotal phase 3 clinical trials, the INSURE-1 and INSURE-2 trials, and also in the phase 2 efficacy study in PMS called Celiac. With IMU-935, we have a second oral drug in development targeting chronic inflammatory disorders. IMU-935 is currently tested clinically in psoriasis and CRPC. But today, the focus is on IMU-856, an innovative new molecule which is in phase 1 clinical development for the restoration of the intestinal barrier function. IMU-856 uses a novel mechanism of action and has already provided very good safety and tolerability data in healthy human subjects, which we published last summer. We are currently evaluating the effect of IMU-856 in patients with celiac disease who are controlling their disease on a gluten-free diet. We expect data from this clinical trial mid of this year. With this, I would like to hand over to Andreas Müller, our co-founder and Chief Medical Officer at Immunic. Andreas.
Thank you very much, Daniel. I will start the webcast with a short introduction into celiac disease as a disease. We would like to convince you today in this webcast that celiac disease is a serious, lifelong autoimmune disease. This is not a food allergy, food incompatibility, or food sensitivity. In celiac disease, an autoantigen is recognized by our immune cells, and an immune reaction is then triggered. Celiac disease is a gluten-related disease. Gluten is a general name for the proteins found in wheat, rye, barley, and other grains. However, gluten can be found in many types of food, even ones that would not be expected. In the bowel lumen, gluten is broken down and the resultant gliadin peptides are taken up in the gut. Gliadin is then deaminated by an enzyme called transglutaminase, or TG2, an enzyme that you will hear on several occasions in this webcast today. Normally, gliadin and deaminated gliadin are not acting as autoantigens. However, when our immune cells have certain gene variants for the HLA class II receptors, these are receptors that are involved in the presentation and recognition of antigens, then the TG2 enzyme in conjunction with deaminated gliadin may mistakenly be recognized by our immune system and act as autoantigens. Later on, we will see that the autoantibodies against TG2 and deaminated gliadin, therefore, are also used for diagnosis of celiac disease. In principle, all patients with celiac disease present with HLA classes DQ2 or DQA variants, but not all humans with these HLA gene variants will suffer from celiac disease. Other factors may play a role to trigger celiac disease in a particular patient. In celiac disease patients, the deaminated gliadin resulting from gluten ingestion triggers a strong immune response in both the innate and adaptive immune systems. Pro-inflammatory cytokines are released that result in local inflammation of the bowel wall and then subsequently leading to the two hallmarks of the pathophysiology of this disease. These are increased intestinal permeability and epithelial and mucosal damage. The main measurable cytokine that can be used as a biomarker in celiac disease is interleukin-2 or IL-2. It is an acute phase cytokine and it can be measured in the patient's blood within a few hours of gluten ingestion. We will hear more about the value of IL-2 as the most important biomarker in celiac disease today. The cytokine IL-2 is also known to be closely linked to the main symptoms of celiac disease, particularly diarrhea, nausea, and vomiting. But celiac disease is a serious disease because in its chronic form, it will lead to the destruction of the bowel epithelial architecture. It's also called villus atrophy and leads to malnutrition, malabsorption, and other serious consequences. More to come on this topic later as well in this podcast. There is no known or available therapy for celiac disease. The only option for patients to live with their disease is a lifelong, strict adherence to a gluten-free diet. The amount of gluten required to maintain disease activity and autoimmune reactions are minuscule. This makes it so difficult to effectively maintain a gluten-free diet. The illustration shows that just a very small crumb of bread per day will lead to ongoing disease symptoms and inflammation in your gut. This makes it so difficult for patients to avoid gluten to the extent necessary. Involuntary or unintentional gluten exposure is an almost unavoidable problem for celiac disease patients, and this contributes to the quality of life issues for them. Inadvertent gluten exposure for patients is very common, despite their best efforts for a gluten-free diet. Many non-food products contain gluten in small amounts, such as cosmetics or supplements. Contaminations can also happen in your own kitchen, shared with family members, or gluten-free foods that have been processed on the same machinery as grains. There are also patients that have a slow response to gluten withdrawal after diagnosis with celiac disease. All of this leads to the known fact that about a quarter to a half of the patients have active ongoing celiac disease, despite them strictly adhering to a gluten-free diet. The patients with ongoing active celiac disease, or OACD, are the main unmet medical need in celiac disease and the target for drug development, since OECD has serious medical consequences. New medications need to result in avoiding or reversing these symptoms, as well as avoiding the destruction of the bowel architecture. This is also recognized by the FDA as their new guidelines focus on medications to be used in OECD patients as an adjunct to gluten-free diet, to be discussed later in the podcast. There are numerous large studies that consistently show that on average around 40% of celiac disease patients on gluten-free diet have a destruction of the bowel architecture called villus atrophy. They are very well recognized histological markers that are assessed in duodenal biopsies in these patients to confirm such villus atrophy. This patient population with OECD and villus atrophy is not only large in numbers, but also is a burden to the healthcare system and payers because of its serious consequences. This patient population is the main target for the development of new medications for celiac disease. This slide shows an illustration of the many serious consequences of active ongoing celiac disease, or OECD. The consequences are not restricted to the gastrointestinal system. The resulting malnutrition and malabsorption affects basically all body systems, including the central nervous system, liver, skin, bones and joints, growth and repair mechanism, and include the risks of some cancer. Given the current culture of recreational gluten avoidance, the dire consequences for patients with this serious autoimmune disease are often forgotten or remain unrecognized. This slide summarizes the effects of gluten exposure over time, independent whether this is an inadvertent gluten exposure in OECD patients or applied as a gluten challenge as part of a clinical trial. Already following an initial single dose of gluten, the patient will have an immediate gastrointestinal symptoms measurable with validated clinical scales. As said before, within 2 to 4 hours, a dramatic increase in IL-2 in the blood serum of patients can also be detected. When gluten exposure extends over several days, symptoms for the patients will extend to fatigue and other general symptoms which affect physical and social activities. Within very few weeks of ongoing gluten exposure, the gut architecture is already affected. This is usually quantified in histology from a biopsy taken from the first part of the small bowel called the duodenum. In such biopsies, there are markers for the appearance of the bowel architecture and for the presence of immune cells. Both will be explained later in this webcast. With longer exposure to gluten, the changes in the bowel architecture will lead to signs of malnutrition and malabsorption, in addition to symptoms and deterioration of quality of life for these patients. It is also important to know that serology, for example, the presence of TG2 or gliadin antibodies in the blood of patients, which are then called seropositive, can be a measure of ongoing chronic gluten exposure. Not all patients with ongoing active celiac disease, defined through their biopsy appearance, are seropositive. The serology, however, may allow to monitor their general acute or chronic exposure to inadvertent gluten. This serology status is later important when discussing results of clinical trials in OECD patients. So let's come now to the prevalence and of the celiac disease. Celiac disease is not a rare disease. Celiac disease is a major public health problem with an approximate prevalence of around 1.4%. In the US, celiac disease is estimated to have been diagnosed in more than 2 million patients. Another 1 million patients are estimated to remain undiagnosed. By comparison, the prevalence of celiac disease reaches almost the same prevalence as the prevalence of all chronic liver diseases and cirrhosis, liver cirrhosis, according to CDC data. The diagnostic tool for celiac disease have very much been revolutionized in the last years and allow now for more objective criteria. This has led to an apparent increase in the prevalence of celiac disease. However, it's believed to be tied to better diagnostic criteria rather than a true increase in prevalence. In difference to other gastrointestinal diseases, celiac disease does not seem to be favored with Western food patterns, but it's a global disease connected to general grain consumption. Celiac disease is being diagnosed beginning at childhood and throughout adulthood. The median age of diagnosis is about 40 years of age. However, it needs to be taken into account that there's a sizable diagnostic delay between the onset of symptoms and diagnosis of celiac disease. In several studies, there's about a decade of diagnostic delay for these patients. This is very unfortunate, since this may delay the start of strict gluten-free diet and may lead to gastrointestinal damage already being present at diagnosis. The main difficulty with the diagnosis of celiac disease is that initial symptoms are often uncharacteristic and can mimic the presence of other diseases. The exclusion of other diseases that are initially suspected to account for these symptoms often contributes to the diagnostic delay. The diagnostic tools for celiac disease have very much improved over the last years, and this may make diagnosis of celiac disease quicker and more objective in the future. The main tool for diagnosis is serology, the presence of certain markers in the blood. As mentioned earlier, presence of antibodies against the enzyme GG2 and against the deaminated gliadin peptides are characteristic for celiac disease. However, patients may turn seronegative if a strict gluten-free diet has been followed for some time. Here, a gluten challenge test or the genotyping for the HLA types are allowing the diagnosis in seronegative patients. In most celiac disease guidelines in developed healthcare systems, a confirmatory small intestinal biopsy as part of a gastroscopy is recommended to evaluate the gastrointestinal architecture. So what do we see in the biopsy of a celiac disease patients? In well-controlled celiac disease patients on the left side, we would see a normal or almost normal bowel architecture, but with higher presence of lymphocyte, in particular at the tip of bowel villi. These are the nutrient-absorbing filaments of the bowel wall that's protruding into the bowel lumen. In patients with ongoing active celiac disease or OECD on the right side, there's a substantial change in the bowel architecture. Villi are much shorter, and crypts at the base of the bowel wall are more elongated. This is used as a quantitative marker called villus height to crypt depth ratio. Additionally, the number of intraepithelial lymphocytes is more extensive. Histology is an important objective tool for the diagnosis of celiac disease patients, for the quantitative assessment of the stage of disease, and also as an objective endpoint in clinical trials. For the histological appearance of bowel architecture, the Marsh-Oberhuber classification has generally been accepted in clinical routine. For clinical trials, the quantitative version of the Marsh-Oberhuber score, also called Q-Marsh, has been the mainly used objective measurements. This uses the quantification of villi height and crypt depth. Patient with a Q-Marsh stage M3A or worse, which is in dark blue in our table here, are considered patients with ongoing active celiac disease or OECD. Those patients would be used for clinical trials in pivotal clinical trials, and improvement of the Q-Marsh score would be part of the main approval of the approval relevant endpoints. So let's now switch to the celiac disease treatment landscape, and maybe we start with some of the investigational treatments that are now in development. This section of the webcast would give an overview of proposed mechanisms to treat celiac disease patients and some of the initial clinical trial results. There's a range of proposed mechanisms for potential pharmaceutical treatments effective in celiac disease. Some proposed mechanisms focus on lowering the insult or trigger to the immune system, either through modifying gluten in the bowel lumen before absorption, or by normalizing the increased bowel wall permeability that's promoting influx of gliadin and into the bowel wall. Other proposed mechanisms focus more on the lowering of the immune response to the autoantigen, either through achieving greater immune tolerance, reduced TG2 enzyme activity, or using immunosuppressive strategies. The last proposed mechanism is repairing the barrier damage. One of the main components of the disease, in particular in OECD, is the presence of villus atrophy. It is known and well established that crypt cells in the bowel wall are the driver for regeneration of the bowel architecture. We do believe that repair of the architectural damage and improvement of the bowel architectures need to be an integral part of the pharmaceutical treatments in celiac disease. In this webcast, we will present Immunic's preclinical data indicating that IMU-856 seems to promote such regeneration mechanisms. But let's first look on the clinical trial in celiac disease that are available at this point. This slide summarizes the clinical trial results for latiglutenase. This is a combination of two enzymes called proteases that chemically modify gluten in the stomach and bowel lumen, and are thought to remove immunotoxic gluten sequences. The mechanism is therefore focused on patients that have an ongoing gluten exposure and reduce the amount of and immunogenicity of gluten. In a long-term gluten challenge study, this is summarized on the right side of this slide, latiglutenase has shown a good effect in preventing gluten-related damage to the bowel architecture. This provided a proof of concept for this proposed therapeutic principle to lower the trigger or insult. When used in OECD patients, this is summarized on the left side of the slide, the main target population for a regulatory development pathway. The results, however, were mixed. Positive effects on celiac disease symptoms were restricted to the subpopulation of seropositive patients. Those are those patients having antibody markers in their blood, presumably to the ongoing gluten exposure. However, there was no improvement in bowel architecture and in the amount of immune cells in the bowel wall in the study overall. These results would indicate that a strong focus of the mechanism on gluten reduction alone without secondary mechanisms to promote barrier repair or barrier regeneration may not be addressing all of the needs in seronegative OECD patients. Next slide. Okay. This slide summarizes the clinical trials for a transglutaminase inhibitor. Transglutaminase is the enzyme that deaminates gliadin to produce the autoantigen. TG2 itself is also part of the autoantigen and is therefore also part of the cascade of immune stimulation. This proposed mechanism is therefore targeting to lower the gluten-induced epithelial damage and immune stimulation. In a long-term gluten challenge study over 6 weeks, summarized on the right side of the slide, the medication is shown to prevent gluten-related damage to the bowel architecture. This provided proof of concept for this proposed therapeutic principle. The left side of the slide summarizes the ongoing trial in OECD patients for which no results are available yet. We believe that this development candidate has a strong focus on the reduction of gluten-induced immune activation without, as far as we know, secondary mechanisms to promote barrier repair or barrier regeneration. This slide now summarizes what we believe to be the main mechanisms of action for Immunic's IMU-856 development candidate. The newly discovered epigenetic target, which is addressed by IMU-856, has shown effects to normalize bowel permeability and also promote regeneration of the epithelial barrier while maintaining full immunocompetency. We believe that having all of these effects make IMU-856 unique among the proposed development candidates in the treatment for celiac disease. We will later in this webcast hear more details about the preclinical studies that highlight these effects. While the mechanisms of IMU-856 are in perfect alignment with the unmet needs in OECD patients, the mechanism of action does not specifically focus on gluten or requires the presence of gluten, for example, in seronegative OECD patients. We therefore believe that although the celiac disease population is a great fit for IMU-856, the mechanism of IMU-856 will also be applicable to other gastrointestinal diseases. Gluten-specific mechanism may therefore have their limits in the applicability to other indications. There are other important gastrointestinal diseases that are known to be tied to an increase in bowel permeability and require restoration of the epithelial barrier in the gut, similar to celiac disease. Strengthening and restoring the bowel barrier function may also prohibit the interaction between the bowel microbiome and immune cells in the bowel wall, which is a driving force in the disease processes of important gastrointestinal diseases. In patients with Crohn's disease, these are the data shown on the left side on the slide, it is known that increased bowel permeability precedes a potential disease relapse, and the increased possibility of interaction between the microbiome and the bowel immune system may be the trigger for relapse. Normalizing bowel permeability may therefore promote maintaining remission in these patients. In patients with irritable bowel syndrome, or IBS, these are the data shown on the right side of the slide. It was shown that IBS patients with a diarrhea predominant form called IBSD have an increased bowel permeability, very similar to inflammatory bowel disease, such as ulcerative colitis. One of the hypotheses for the pathophysiology behind IBSD is the interaction between the microbiome and mast cells in the bowel wall. Normalizing bowel permeability may therefore promote symptom reduction in these patients. Immunic believes that IMU-856 may therefore has applicability well beyond celiac disease, but celiac disease presents a good opportunity to provide a proof of concept and a potential significant indication of use with high unmet medical need. So let's go into what kind of interest have you seen by the pharmaceutical industry? Immunic has always believed that patients with celiac disease have a large unmet medical need and provide a substantial opportunity for IMU-856. We are very pleased to see that other members of the pharmaceutical industry begin to share our enthusiasm for the celiac disease space. In 2022, there was an uptick in significant partnerships between biotech and pharmaceutical companies focusing on development of treatments for patients with celiac disease. The reason behind this uptick in interest in celiac disease are manifold and have recently been paralleled by the FDA providing the first draft guidance in this indication. The prevalence of celiac disease is high, and there is a large proportion of patients that have ongoing active celiac disease or OACD, for which strict adherence to gluten-free diet does not provide symptom relief. The sustained destruction of the bowel architecture in OACD patients leads to serious medical consequences. This is a lifelong autoimmune disease, and the persistent symptoms influence quality of life as well as physical and social activity for patients. There are no treatments available at the moment that can address the needs of OACD patients. In addition, the FDA has clarified now their expectations for an acceptable approval pathway and pivotal study endpoints. This really provides better clarity and reduces development risk for pharmaceutical companies. The indication of celiac disease is also a great fit for those pharmaceutical companies which already have a strong presence in gastroenterology, as there's a large overlap in prescribers between celiac disease and other major GI diseases. This potentially makes celiac disease a natural complement to their current commercial presence. So let's focus now on the changes in the FDA guidelines, which I think are very exciting. I had now mentioned several times that the FDA has clarified now the expectations for the development pathway in celiac disease. Let's look at this in more detail. In anticipation of drafting guidelines, the FDA had performed initially a workshop in 21, and had invited clinical experts as well as members of industry. Then in 2022, the FDA published the first ever draft guidelines for the development of medications in celiac disease. This also shows that the FDA sees the unmet medical need and encourages medication candidates to be tested in this indication. The draft guidelines clarified that the target population and indication in celiac disease and the endpoint acceptable for regulatory approval by the FDA in this indication. The FDA asked Clinical develops to focus on medication as an adjunct to gluten-free diet in patients that have ongoing symptomatic disease. More specifically, they do recommend that pivotal trials are done using screening histology to confirm villus atrophy. That means the FDA fully wants drug developers to look into the population defined as OECD, as discussed earlier in this webcast. The recommendations by the FDA regarding celiac disease are quite consistent with their recommendations for pivotal trial endpoints in other major gastrointestinal diseases regulated by the same division. The FDA expects placebo-controlled randomized trials over 52 weeks. The primary endpoint should be a composite endpoint consisting of an objective outcome measure and a patient-reported outcome. For celiac disease, this was defined as an improvement in histology based on Marsh-Oberhuber classification discussed earlier here, and an improvement in the most important symptoms of celiac disease. The FDA also clarified the design for early clinical trials as gluten challenge can be used by drug developers to provide proof of concept and provide information on dose response. As seen earlier in this clinical trial section of this webcast, gluten challenge can be a very valuable tool in early celiac disease trials, and the FDA confirmed that such early studies may be performed in well-controlled celiac disease patients. The FDA defined that gluten challenge should be done with a duration between 2 and 12 weeks and using doses of 3 to 6 grams of gluten daily. The agency also recommended to include duodenal biopsy during gastroscopy. We would like to confirm that Immunic fulfills all of these mentioned recommendations of the FDA within their ongoing Part C of the phase 1 trial of IMU 856. We will now focus on an important biomarker, IL-2, that I mentioned earlier, and this is an essential part of the gluten challenge study. We have our first expert speaker here that will elaborate more on the value of these biomarkers. We will also point out that IL-2 response is the major readout in early proof of concept studies in celiac disease and will be as well for Immunic's phase 1 study. First of all, this slide shows you that the change in IL-2 levels in serum is very quick and can be monitored effectively in blood serum. In addition, the IL-2 response is related to the dose of gluten used. Hence, a lowered IL-2 response by pharmaceutical intervention could be monitored through this biomarker as well. The IL-2 response seems to be a graduated response related to immune stimulation. This slide depicts the data that this biomarker also seems to be clinically relevant. The IL-2 response quite well corresponds to the symptom severity experienced by patients. And I'm sure that our expert speakers will elaborate more on this. So let's introduce our first speaker here, Dr. Joe Murray from Mayo Clinic. I really would like to, I'm very excited that he's part of our webcast here, and I want to thank you for all of the interactions we had in the past, Dr. Murray. So Dr. Murray is a professor of medicine at the Mayo Clinic in Rochester, Minnesota. He's also very well recognized in the field of celiac disease studies and also treatments. He's the founder and president-elect of the North American Society for the Study of Celiac Disease, the founder of Celiac Disease Foundation. And Joe, I'm personally, I think I'm very pleased that I've met interactions with you, and thank you for participating here.
Well, thank you very much for the opportunity to address some specific issues relating to celiac disease, especially the role of IL-2 and what we now recognize as a T-cell driven disease. And our next slide just shows my disclosures, and it reflects a greatly increased interest in celiac disease. Almost all of these are related to celiac disease. Next slide. We think of celiac disease as an evolution. It starts from a threshold, somebody with genetic risk. That's fully 1/3 of the population are at genetic risk. And then with ongoing exposure to gluten, and perhaps overlapping with some triggering events that drive, presumably through an innate stimulus, possibly also involving some microbiome changes, viral infections, especially in young children, potentially bacterial infections in adults, may then drive this expansion of this immune response. It starts with autoantibody changes are seen relatively early. You have epitopes spreading across the epitopes related to gluten. And then there may be augmenting events that further amplify this response, shown here in purple. And this is a phase when we often have undiagnosed celiac disease, when patients are starting to reach that threshold for symptomatology. And eventually then they develop fully evolved clinically detected celiac disease, where there is activation of both T cells and B cells in particular. And you get the inflammation and destruction that we've already heard about. On the next slide, again, to bring us back, this is an inflammatory disorder. It really is like inflammatory bowel disease. It's a chronic inflammatory state of the small intestine. It occurs in those individuals who are genetically predisposed. And while let's say it resolves, it improves with exclusion of dietary gluten. There are certainly a good proportion of patients where it will completely reverse. However, even within the healed intestine of patients with celiac disease, there is a very deep immune memory that maintains a high fidelity for responsiveness to the same gluten peptides that the individual responded to initially. So there is a very deep memory that is built there that means it's a permanent intolerance to gluten, at least thus far. Our next slide. This is an illustration on the left-hand side of the various of an immunofluorescence stain showing a variety of cells. There are T cells in green, and they populate the very surface epithelium, and they're termed intraepithelial lymphocytes. They're cytotoxic CD8 cells. They cause damage to the epithelium. There are also some T cells in the lamina propria, and they're typically CD4 cells, and they are what I would call the intelligent part of the reaction to gluten. And it's also within even the healed intestine that there are CD4 positive memory cells, memory effector cells that reside there that can recapitulate that response relatively quickly. And we'll talk about that when it gets to IL-2. There are lots of plasma cells, and plasma cells are not only producing antibodies against gluten and against even self-antigens like transglutaminase, but they also may be involved in antigen presentation within the intestine. So keeping the antigen away from these cells may be a key pathway that one could intervene or prevent the responsiveness to gluten in patients with celiac disease. And of course, along the surface in purple are epithelial cells. And those cells, while they're not the most intelligent cells in this whole merry choreography, they do play a crucial role both as a target for inflammation and for destruction, but they also elaborate cytokines like IL-21 or IL-15 that are involved in amplifying the response. So the health and integrity of the epithelial cells is critical for health, but also is an important target in celiac disease and the destruction that occurs. In the right-hand side, we see this connection illustrated between the plasma cell in red and the gluten-specific CD4 positive T cells, and that it may well be plasma cells that are the dominant antigen presenting cell that are presenting the gliadin and often probably modified gliadin epitopes to those T cells. And that interaction then develops or elaborates a gamma interferon-based and driven response that then amplifies that cytotoxic CD8 cytotoxic effect on the epithelium, where you get epithelial inflammation and destruction. And again, epithelium, a key role also is played in the transport of the antigens across from the lumen into the lamina propria to allow for that presentation. And there's both transcellular as well as paracellular uptake of antigens that have been described. So the epithelium is very much the center of entry of antigen, but also as a target for inflammation and destruction, and itself, when it is perturbed, becomes a magnifier, amplifier of that inflammation through a cytokine IL-15. In the next slide, this just illustrates the histology. And Daniel has already talked about quantitative histology. That's measuring the types of damage or the degree of damage. And this just illustrates that a spectrum of injury or progress of injury, that when you challenge somebody with celiac disease, with gluten going from left to right, you get increasing destruction. When you withdraw gluten from the patient, you go from destruction to improvement. If it only were always so predictable that one could get complete mucosal recovery for a gluten-free diet, but that unfortunately is frequently never achieved, especially in patients diagnosed as adults. And a high proportion of patients out there thinking they're doing okay may actually have substantial inflammation and tissue destruction, which puts them at risk of long-term complications. But again, we think of this continuum. However, even in patients who have achieved the apparent complete healing in the that's seen in the left-hand panel, when gluten is reintroduced, you will get the damage back. Even if it's 20 years since they've seen gluten, there is that very strong memory response. Next slide. Well, I want to focus a little bit on what we've learned from human trials in celiac disease and very briefly touch on the effects of gluten challenge. Next. So our interest in the immediate responses to gluten was really driven by Bob Anderson and his group, especially when he had the NextVax Immunosan-T project, where they're attempting to induce tolerance by injecting using epitope-specific immunotherapy. And one of the first observations that they had is when they gave intradermal injections of immunodominant peptides, and they identified 3 immunodominant peptides that seem to be common across many patients with celiac disease, and they injected them intradermally. So these are naked injection of antigens without any adjuvant, and it produced, in patients where they got a little bit higher dose, it induced symptoms that occurred quite acutely within 2 to 4 hours. And many of us in the field had kind of regarded the responses to gluten as being slow, that it took weeks to get the type of accelerated inflammation and damage that ended up with, clinical responses to challenge. But what he showed is by injecting these immunodominant peptides in relatively small amounts, in the microgram amounts, into the dermis of patients with treated celiac disease, he produced symptoms within a couple of hours, and in a couple of patients, fairly dramatic symptoms. And he also demonstrated that there was a significant, very rapid response of cytokines. Now, on the right-hand side, this wheel, I know it's probably a little bit small, but this wheel represents a whole slew of cytokines. And each cytokine, the further out from the center you are, the greater the degree of cytokine production. And one can see that there is a lot of IL-2, MCP, IL-6, CGRP, IL-10, a whole series of cytokines that begin to be produced very quickly after exposure to these very tiny doses of cytokines. Now, as part of their study, they were able to show that they could tolerize people to these specific peptides, though the story continues. We go to the next slide. And they led to the initial promising studies in phase 1 led to a large phase 2. And this was basically, we'll come back to that study. We also studied that in our lab, where we were very interested in why patients get symptoms fairly quickly. Within an hour or two of eating gluten, they would get symptoms. And why was that happening? And in parallel with the studies from Australia, we also wanted to study this. However, I've often suspected that patients with celiac disease who get symptoms assume it's due to gluten, or if you give them gluten or something that might contain gluten, that they get what we call a nocebo response. They're expecting there to be a problem, so they get symptoms. And this has often been used, this worry about getting symptoms after a suspected exposure to gluten is often used not only for patients to increase anxiety in patients with celiac disease, but also is used to self-justify gluten sensitivity. Very little control data. So what we did was we took individuals with biopsy-proven celiac disease who had healed. We took patients with apparent gluten sensitivity who did not have celiac disease, and we took healthy controls. And we gave them either gluten or a sham challenge, masked, but they did realize that there was a high risk they would actually get gluten. And then we followed their symptoms hour by hour, as well as obtaining a whole variety of other things to look at this response to a single dose. And we'll go to the next slide. And basically, this was not a big study. It was 20 patients with celiac disease, 20 patients with non-celiac gluten sensitivity, and there was also patients with control patients who didn't have either issue. And we'll go to the next slide. And basically, this illustrates some of our data. So on the left-hand side are the responses of patients to gluten versus sham. And anything that's colored pink illustrates early symptom responses. Typically, things like abdominal bloating, fatigue, and nausea were very common symptoms. But as you can see from this illustration, these two boxes, colored boxes, illustrate the non-celiac gluten sensitivity individuals. Most of them were getting symptoms, and a lot of it was nocebo. We also saw a lot of symptoms in celiac patients, and there was some patients who got symptoms with sham. So they were getting a nocebo response, even though they did not get a gluten challenge. However, when you look at the right-hand illustrations, these illustrate the IL-2 responses from baseline. And they show that only in the top left box, those are the celiac patients getting gluten, was there a rise in IL-2 seen. In the top right, the celiac patients who got placebo or a sham challenge did not have a change in IL-2. The middle boxes and the lower boxes were the non-celiac gluten sensitivity and the controls. So this illustrated that IL-2 seems to be quite specific to celiac patients who are treated already getting gluten. Next, please. This is data, and I've just aggregated some data. We've seen already the graph on the right from Daniel's presentation. But basically, there are now a number of studies that illustrate that this IL-2 is elevated in celiac patients within hours of gluten ingestion. What is key is that patients have to be treated. If you do this in an untreated patient who is on a gluten-containing diet and you give them more gluten, it doesn't change at all. And it's not observed in healthy controls. The issue of, and certainly from the Australian studies, there is a strong indication that the magnitude of the IL-2 response correlates with severity of symptoms experienced by patients. Our paper would also suggest that there can be a nocebo response, and that is something I think that's important to take account of when you're doing challenge studies in patients with celiac disease, that you consider whether a sham arm is necessary. Next slide. This is just the detail of what Bob Anderson's group at Immunic undertook for examining responses to a variety of gluten challenges, the type of analysis that they looked at. There are some particular issues, I think, that need to be considered. One, they used very sensitive cytokine panels, some of which had to be adjusted to reach to the lower end of their measurable range in order to accurately identify changes in IL-2. So these are relatively small changes in terms of an assay. It's not a cytokine storm level of response. It is measurable and it is reproducible, but it does take a very great care in the analytic lab to do this right. Next slide. This is just a heat map from one of their papers looking at, and it's almost always illustrated normalized peak fold change in cytokine levels. And you can see the celiac box on the left-hand side, 25 celiac patients, that virtually all of them had an increase in IL-2. There is a small number who don't. And in our population, we had about, I think it was 3 out of 10 where we did not see a significant rise in IL-2. But in this Australian group, you can see there are probably 3 or 4 patients out of the 25 who do not have a significant rise in IL-2. CCL20, which is involved in homing chemokines, is also increased in virtually all patients, IL-17, and you can kind of move down where you see lesser proportions of patients have responses with some of the other cytokines. Some of those could be related to timing of the dosing or the responses. Of course, these cytokines are probably coming from the gut. So their major impact is in the gut, and when we measure them in the serum or plasma, we are really simply reflecting what's reached the systemic side. And of course, the non-celiacs don't show any such response. Next. I want to come back to the Immunosanté program. Everything, of course, in that program was bet on this reset study design, a very intense trial done in the US, Australia, New Zealand. It's worth pointing out that many of the patients actually came from Australia, is where many of the early patients were recruited into this trial. A very intense study, 49 visits for patients. Patients had to be biopsy proven, and then they received this tolerance methodology with these 3 immunodominant peptides injected into the skin and then followed up. And they had a number of masked challenges, either got gluten or sham. And we'll go to the next slide. And their major outcome was looking at symptoms and looking at IL-2 after gluten. And this hasn't actually been published. It was presented by Bob Anderson at a couple of meetings. He tells me it's in press. And so we'll actually see this in press. But basically, it showed that in patients who were treated with placebo on the right, and we'll take that first, those who got gluten had a significant rise in their IL-2 before and after the placebo treatment. The sham did not induce an IL-2 response, which is expected. But on the left-hand side were the patients treated with Nexfax. And it showed that, unfortunately, neither symptoms nor IL-2 was blocked by the Nexfax treatment, suggesting that the therapy as administered was not potent enough to provide tolerance to this degree of gluten challenge. Now, it is a high bar. I would kind of comment that the amount of gluten given is a relatively high bar. If you were doing a peanut challenge experiment, for somebody with peanut allergy, it's like giving them, a whole handful of peanuts, not one peanut. So you are asking a lot of this particular tolerance methodology. And of course, the other theoretical issue is that giving 3 immunodominant peptides in a disease to try and induce tolerance in a disease where patients might react to 10, 15, or 20 different epitopes might be asking a little too much of a peptide cocktail. Might be. But also the engagement of tolerance may not have been sufficient to provide the tolerance, certainly to block the IL-2 response. Next slide. So that trial failed and Immunosanté evaporated as an entity. Next slide. This is data that I presented at Digestive Disease Week, so it has been presented publicly, using an agent, another tolerogenic agent, CAN101, which targets the liver to induce tolerance to gliadin. Next slide. And this is just to illustrate this notion of T cell responses driving the disease itself, that you can have a healthy looking intestine in a patient with celiac disease. You get dietary gluten that gets through the epithelium. You trigger these long-lived gluten-specific T cell responses. And this drives a pro-inflammatory response dominated by interferon gamma, especially also with IL-2 release that occurs early, as we've talked about. Next slide. This was just a schedule of the trial where we gave 3 doses of the drug or placebo, and then gave a 3-day substantial gluten challenge. So this is a fairly common design. You give 3 days of 9 grams of vital wheat gluten per day for those 3 days, and then you have follow-up measures both on day 1 immediately after the first dose, but also then on the 6th and 7th day, on day of after the gluten challenge is initiated, to look at immune responses. And next slide. This shows a whole blood restimulation assay. So you take blood from the patient and you expose that whole blood to your antigen in a true culture tube and look at the responses as measured by IL-2 in the supernatant. In the left-hand graph in red is the placebo-treated patient, showing a significant rise in IL-2, and those levels are essentially blunted or blocked by the patients and the patients that were treated with CAN 101, supportive of a proof of concept effect. We go to the next slide. This looks at cytokine in the serum after that first dose of the gluten challenge. So when you're looking at these responses, you look after the first dose for the serum cytokine IL-2 response at 4 hours and 6 hours afterwards in particular. And we can see in the left-hand side is what you expect with placebo. All of the patients had a significant response, a rise in IL-2. We still saw that in the patients who got the lowest dose of the agent. It started to see some effect at the 0.3, and then with the 0.6, a substantial proportion of the patients had no IL-2 response. And this is important, and this is with a gluten challenge and looking at cytokine responses. It's not looking at a specific antigen, like just looking at a gliadin peptide-induced response, like you would with a whole blood challenge. This is looking at a whole gluten challenge in the intact person. So again, this is illustrating its use in a proof of concept study. Next. So in summary, celiac disease is a T-cell dependent disease. T-cells see and react to an array of gliadin epitopes. These gliadin-specific T-cell responses are incorporated into memory. IL-2 is likely the earliest detectable cytokine response to gluten, and it seems to be specific to gluten in treated celiac patients. These responses occur rapidly in treated patients who have not seen gluten for some time, and the IL-2 responses seem to be specific for gluten. They don't happen, for example, with the sham challenge. And IL-2 seems to be a good marker, at least as it's been used to assess treatment effects and potentially effective dose levels, for example, with the example I have shown. Thank you for your attention.
Yeah. Thank you very much, Dr. Murray, for your insightful presentation today on celiac disease and IL-2. A Q&A session with our 2 experts will start after the next KOL presentation. And I would like to hand over to our CSO, Dr. Hella Kohlhoff now.
Hello. So I would like to give you some insight into IMU-856 target expression and modulation thereof, and how IMU-856 positively impacts intestinal barrier. IMU-856 targets and modulates an epigenetic protein. This epigenetic protein is predominantly expressed in intestinal epithelial cells within the intestinal crypts. You see in the histology on the left the staining of this epigenetic protein in brown, and that it is predominantly expressed in the crypt areas of colon and small intestine. On the right, you see the target protein expression, here in human biopsies taken from IBD patients, as a pink signal in epithelial cells in the crypts. IMU-856 is a small molecule modulator, inhibiting the enzymatic activity of its target. It thereby exhibits a high selectivity over other protein family members, what you can see from the dose-response curves on the left. Interestingly, it is the unique binding mode of IMU-856 that allows for the high selectivity over other subtypes of this family. The IC50 of IMU-856 determined in the cell-free test system is 15 nanomolar. As typical for epigenetic targets, the inhibition of the enzyme activity by IMU-856 is even more pronounced in a cellular test system with an IC50 as low as 4.3 nanomolar. IMU-856 improves the intestinal barrier function. As a test system, we use the epithelial cell line CACO2, which can be cultured on a membrane as a monolayer and forms a tight barrier. In a so-called tear assay, you can measure the tightness of the cellular lining. The better the tightness between the cells, the higher the electrical resistance. In this test system, the tightness of the formed barrier was challenged by administration of a pro-inflammatory cytokine, which reduced the tightness of the barrier. As you can see on the right, the addition of IMU-856 led to a dose-dependent recovery of the barrier. From these in vitro results, we conclude that IMU-856 may restore epithelial barrier integrity after destructive cytokine challenge. But how does it work? Since the intestinal barrier in the body needs to be tightly regulated to allow proper uptake of nutrients, but preventing unwanted interaction of, for example, luminal bacteria with the immune system of the gut, there seemed to be a very complex mechanism involved. Our initial hypothesis here is that IMU-856 impacts tight junction protein expression and thereby restores the barrier integrity. Of course, there are many more proteins involved in epithelial cell interaction, but I would like to focus today on Claudin 1 and Claudin 2. Very simplified, downregulation of the pro-tightness Claudin 1 and upregulation of the pore-forming Claudin 2 would be in line with the disruption of the gut architecture. For example, after a cytokine challenge with the pro-inflammatory cytokine IL-6 would be used here. This can be seen in the Western blot image highlighted in the red box in the middle. By adding IMU-856 counteracts this unfavorable modulation of Claudin 1 and 2 by upregulation of Claudin 1 and downregulation of the pore-forming Claudin 2, supporting the restoration of the epithelial cell interaction. To investigate the impact of IMU-856 on the regeneration of the gut architecture, we used a mouse DSS colitis model. DSS induced here a destruction of the gut, which can be seen in changes of the morphology of crypts. During homeostasis, you have normal crypts versus injury in this model leads to atrophic crypts. From histology slices, as you see on the right, we counted the number of normal and atrophic crypts from IMU-856 versus vehicle-treated animals. IMU-856 treatment during the onset of colitis in this DSS model preserves more normal crypts and improves the regeneration. In general, the renewal of intestinal crypt cells enables the regeneration of gut architecture after damage. On the left, you see that this regeneration of the gut architecture is driven by intestinal cells, which are located down in the crypts. This is exactly where IMU-856 target is expressed, what I showed you in the beginning. Analyzing samples from DSS colitis model show that IMU-856 treatment enhances EpCAM-positive epithelial cells and slightly induces the renewal of these cells. Therefore, IMU-856 may improve the regeneration after intestinal damage by enhanced renewal of crypt cells. And now I would like to hand over to Dr. Michael Schumann from the Charité in Berlin. He's a professor of medicine and an expert in mucosal barrier and celiac disease. In his presentation, he will focus on the intestinal barrier function in the pathophysiology of celiac disease and will share research results on the impact of tight junction assembly defects and transcellular gliadin transport. So let's listen to the real expert now.
Thank you Dr. Kohlhoff, for this nice introduction. Can I share my screen now? Because I couldn't in the set. Yeah, now I can. Yes. So I hope you can see my screen, and it's the topic is about varied effects in celiac disease, what we currently know, and some methodological issues. These are my disclosures, and I want to allude to a number of things that you see on that slide. And I want to start with reminding you that we have different mechanisms that cause diarrhea. And we all are aware that celiac disease is mostly caused by a mechanism that we call osmotic diarrhea, where, for instance, something like lactose is not digested by the upper small intestine, and thus it induces extra water flow into the lumen of the intestine. But it's not the only mechanism. There are other mechanisms that are secondary to a defect of the epithelial barrier, and this defect is localized mostly to the paracellular part of the epithelial barrier, and that you can see nicely in this slide on the right-hand side. I hope you can see my my mouse running here. So the paracellular part of the epithelial barrier function is defined by a number of junctional structures that are on the lateral side of the epithelial cells, including the tight junctions and adherence junctions that you can see. And it is then accompanied by a transcellular flow or a transcellular barrier function. The paracellular barrier function being mostly due to the junctional integrity, but also if you have an increased rate of epithelial cell death, you're gonna find paracellular flow. So if you want to modify this barrier function, this paracellular barrier function, you have to either deal with tight junction integrity, or you have to work on your apoptosis rate of the epithelial layer. How are you going to analyze leak flux or permeability? We use those kind of old-fashioned instruments called Assing chambers, named after the Scandinavian Hans Assing, that allow us to give quite detailed analyses on the epithelial barrier function. That looks in the first hand a bit complicated, and it needs to be a bit complicated because if you look at the mucosa, you have a number of layers, and you are actually mostly interested in the most upper layer, the epithelial layer. However, if you just measure permeability, you're going to measure the permeability as a sum of all layers together. And the Assing chamber, or more specifically a technique we call impedance analysis, gives us the chance to tease apart the contribution of the different layers, and to get really only the contribution of the epithelial layer being the important part in barrier function in celiac disease. And you can anticipate that the epithelial barrier function is increased in a celiac patient because that half circle is much smaller than on the left-hand side, where the half circle of a normal or a healthy individual has a decent size. Previous studies by Professor Schulzke showed that celiac patients have indeed a permeability issue on the paracellular part with a reduced barrier function of the paracellular barrier, and they do not have an induction, for example, of the chloride channel, which is a transcellular barrier function. Chloride channel is activated, for example, in the disease cholera, that you presumably know, an infectious disease, where you have a lot of flow through the chloride channel that is on the apical membrane of an epithelial cell. So what has happened over the last years on paracellular research or paracellular barrier research in celiac disease? It started off in the 90s when Alessio Fasano identified a protein he called zonulin that had obviously came from the epithelial layer and had activity on barrier function, came original or had similarities to a bacterial protein that was zonula occludens toxin, and thus he called that protein zonulin. And Professor Schulzke, in the work that I have previously also shown you, showed that not only the measurable function of the cellular barrier is different in celiacs compared to healthy patients, but he also realized the morphological structure, the tight junction, being accordingly changed. And he used electron microscopy to see those wonderful structures that are on the most apical part of the lateral membrane, those called tight junction strands, that were reduced in number. So this network is much more complex in a healthy individual compared to a celiac patient. And the celiac has also strand breaks. Yeah. Further on, Fasano showed the functionality of his zonulin peptide, and we later on realized that the tight junction defect that you are finding in celiacs is quite complex and not only involves claudin 1 and 2, but many claudins, and was presumably orchestrated by a polarity protein that basically can change a number of tight junction proteins. And you see a list of those proteins changed to the upper right of this slide. So that is on paracellular barrier function that can induce a leak flux diarrhea. What about celiac mucosal barrier function and gliadin translocation? And there are a number of issues. There are actually even more, and I focus on 3 ones. And the first one is, what is the function of the microbiota? And there are nice works by various groups. One is the group of Dr. Barone, who has shown that celiac peptides or gliadin peptides are able to mimic viral proteins. So there are viral proteins that induce antiviral immune responses. And for this, it is needed that the viral protein is taken up into the cell. So you have a transcellular uptake. This is an endocytotic uptake. And then the viral protein induces in the cell an interferon alpha response. And Barone's group nicely showed that not only the virus is able to do that, but presumably by accident, certain gliadin, certain alpha gliadin peptide fragments are equally doing that. And Elena Verdú has done a number of works. One of that is shown in this nice sketch where she basically showed proof that certain bacteria are able, for example, Pseudomonas, are able to secrete enzymes that modify gliadin peptides. And this modification changes not only uptake, but also its induction of the immune response in the lamina propria. So you have enzymes that are doing actually 2 things. They allow the gliadin peptides to pass the layer, but also they gonna change the activity on the lamina propria located immune system. So coming back to methodology, we had until recently quite a problem because we had some methodologies using, for example, mucosal explants in Assing chambers that were quite representative, since we had real human tissue coming from the endoscopy unit, where you take by forceps a small piece of the mucosa and implant it into the Assing chamber. But on the other hand, they were devoid of the whole vascular system. So they were, until quite recently, quite alive, but you had basically the problem that they were not supported by the vascular system during the experiment. So that gave you some artifacts. Then you can, of course, use cell lines. And they were pretty easy to manipulate because you can change them genetically. You can do various experiments, but they are actually originally coming from cancer epithelial cells. So the limitation is that they might have changes that you only find in cancer cells and thus are not so representative to the system. And recently we got now organoids, and organoids are primary cell cultures that you can analyze as cell lines on the one hand, but are actually coming from humans, and we can get them also from the endoscopy unit, from the duodenum of celiacs, and then prepare them into single cell cultures first, but then now very recently also get them as a 2D as a layer like structure that we can then analyze in various situations, including the Ussing chamber, but also in newer techniques like the sandwiches I show you in a second. So what we did is that we compared those systems. So on the left-hand side, you see the Keiko BBEs, which we use as a screening system. We used a number of bacteria, not all included in this slide. You can see that if you add bacteria to our system, that not all bacteria will have a deleterious effect on the barrier function. For example, E. coli, K12, or the Saccharomyces cerevisiae do not change barrier function because the transepithelial resistance as a good representative of barrier function stays up. But if you add other bacteria as the Pseudomonas, or also Candida as a fungus, you're gonna get a strong decrease of barrier function. And this was found not only in those cancer cell lines having some problems regarding their cancer origin, but also in original duodenal organoids of patients from the endoscopy unit in a similar fashion. So we were, of course, interested not only in analyzing the barrier function by transepithelial resistance, because transepithelial resistance is basically measuring electrical conductance. And conductance, as you know, of course, works via ions. So it's small ions passing the paracellular barrier. But in celiac, in celiac disease, you don't have the issue only of ions. You actually also have the issue that gliadin needs to pass, and gliadin, of course, is much bigger and of course in another way shaped, and in another way has different charges compared to small ions. So thus it is not comparable, and we looked for another assay that mimics rather the celiac disease situation. And one is the sandwich assay, where you can make use of the biotin evidence system, and you can mark those parts of the barrier that are actually responsible for your macromolecular passage situation or macromolecular barrier defect. And to the right-hand side, you see whole filters that were grown with organoid cells that were incubated with various bacteria, and the more red you get, the more macromolecular passage or barrier defect for macromolecules you have. And you see, similarly to the findings you've previously seen in the transepithelial resistance measurement, you get macromolecular passage once you incubate or expose the cells to certain, but not all bacteria. And you can, of course, using laser scanning microscopy, resolve those leaks in a more detailed fashion as seen in this image. And when you look at those leaks, you can try to correlate that with tight junction protein expression. In this case, we have stained the protein Z01, and you see changes in the tight junction integrity on this molecular or on this protein level after having incubated them the cells with Pseudomonas or Candida. So Candida is actually forming aggregates at which the peptide, the Gluten peptide, might enter the layer, as you can see, or as you can anticipate in those laser scanning microscopy confocal images. So as a conclusion of this section, or take-home message, you can say microbiota, the microbiota of our small intestine really affects gluten uptake, and it might not only be pathogenic strains that were for a long time already in suspicion, because you have just epidemiologically wise a higher proportion of development of celiac disease in patients that have a GI infection, but it might also regard the commensal flora, or flora that not necessarily induces a GI infection. And microbiota also modifies the glidins as polypeptides or as oligopeptides on their way through the epithelial layer. So what I've shown you is not necessarily meaning that they really induce celiac disease. They might support or contribute to the celiac disease situation. However, we know from very old data, as this study in Gut in 1993, that not only celiacs have a changed epithelial barrier function as measured with this lactulose-mannitol ratio, but also their relatives that are actually not sick or diseased of celiac disease. So we got into a collaboration with a Netherlands group around Sibo Without and Iris Jonkers. And they had identified 2 genes where they believed, this was coming out of the whole genome association studies, they believed those genes might actually be important in celiac disease on the one hand, and actually are barrier function genes, rather than, for example, T-cell genes. And they realized that those genes, those mutations or variants they identified in celiacs, are actually inducing an expressional change of the according proteins in celiac patients. So we came up together with the colleagues from the Netherlands with a knockout strategy where we took out the protein in Caco cells. So by CRISPR-Cas, LPP and C1orf106 levels were reduced, and preliminary data of the transepithelial resistance already showed some changes. Looking more closely, not only in the barrier function as measured by transepithelial resistance, but also into the tight junction assembly, we saw changes. This is seen by an assay we call a calcium switch assay, where you basically deplete the cells of calcium and then they open their tight junctions, so they have a huge defect then, and this is seen by the initial drop in resistance in the beginning of the experiment, and then you give them back calcium, and then they can newly evolve or reconstitute tight junctions. So you see how the cell is assembling their tight junction. And in a normal cell that is not a knockout cell, this happens much faster than in those cells that have the knockout. So there is a assembly defect, in fact, by the knockout of those genes. And what we then thought about was that they might have actually a defect in epithelial polarity, and this is what we found in so-called cyst assays, where you always see if there is a polarity defect once you have a number of lumen of the cysts that evolve instead of a single lumen, which you can anticipate in the upper row. And in fact, those both proteins induced multiple lumens and thus have a polarity defect. We are now analyzing the expressional effects of those proteins once you stress the cells with various pro-inflammatory cytokines, and there are differences in their expression after stressing those cells with pro-inflammatory cytokines as well. So, as a take-home message here, barium dysfunction can also be a primary factor in celiac disease and thus modulate the chance to develop celiac disease. And the last part of this talk is about how fast actually can a barium defect evolve. And what we all would think is that it actually takes some time because it's a T-cell derived disease, as we and this is certainly still, of course, the case. But we would guess that since it's mostly a T-cell derived disease, it would take at least hours, if not 1 or 2 days, until you can really see the barium defect. How can we do that in vivo in humans? Well, there is a technique called confocal laser endomicroscopy, and you actually have a confocal microscope at the top of your endoscope. You see that in that sketch. You use IV fluorescence, which ophthalmologists use for decades to look at the retina, and we give it IV, and then the confocal looks through various sections. It resembles like a CT scan, the sectioning. In this case, it's a microscopic sectioning, of course, of the mucosa of the small intestine. So pretty easily done, actually, for an endoscopist. And what we see usually, you see in the upper row, the upper 2 images to the left show you normal villus structure. And you see a wonderful white fluorescence or fluorescein signal coming from intravillus structures. And you see no fluorescence in between the villi, because if it would go into in the room in between the villi, you would have a barium defect because it comes from the mucosal vessels, and it can only go to the lumen of the intestine if there is a barium defect. However, if you add gluten to the mucosa of those patients, you only have to wait 25 minutes, and then you see a certain or a decent amount of fluorescence in the lumen in between the villi, as you can anticipate in the lower 2 images. And this is to us quite a surprise. We do not, we are so far not able to explain this decently, but it's obviously, or for obvious reasons, much faster evolving than we so far believed. So in summary, we should remind us that there is not only osmotic mechanisms of diarrhea, but also leak flux diarrhea, and this is resembling a defective paracellular barrier, which might, of course, be then the reason to see those very fast findings I showed you a second ago, and that there is a role of the microbiota in uptake and modification of Gluten peptides, and that there are celiac barrier genes, actually, not only T-cell genes, but also celiac barrier genes that might modify the course and the development of the disease, celiac disease. Thank you very much for your attention, and I also will be happy to take questions.
Thank you. Thank you, Dr. Schumann, for this very interesting presentation around the role of the intestinal barrier function in the pathophysiology of celiac disease. We will now start our first question and answer session with the 2 KOLs to give the audience of today's webcast the opportunity to discuss with our excellent experts. As a reminder, if you joined the webcast via the Zoom platform, there are 2 ways to submit questions. You can either submit your question in writing via the Q&A tool of the Zoom portal, or if you would like to speak with us directly, please use the raise hand function of the Zoom portal to queue your question. And our first guest today is Andreas Agerides from Wedbush. Andreas, please unmute yourself and go ahead.
Good afternoon, and thank you for the very comprehensive review here. The first question for us here is regarding the upcoming data from Part C of the phase 1. It's going to be a gluten challenge. So around that presentation, maybe for Dr. Murray as well, but well, for the company first, what kind of data do you expect to present, And then for Dr. Murray, you talked about how some of these sham challenged studies tend to have high placebo responses. So can you give us a little bit of a sense of what to expect? Thank you.
Andreas, maybe just quickly from my end, this is the other Andreas. We will touch this right after this Q&A session. So I think I will try to answer your question in the next section of this webcast here.
Okay, so if Dr. Murray wants to just maybe elaborate or expand a bit on kind of the high placebo response, that would be great.
Yeah. Joe, I think
yeah, so I can address the issue of, and I suppose it's really a nocebo response. That is the expectation that I'm going to get symptoms when I'm exposed to gluten or possibly exposed to gluten. And it is very much context dependent as well as patient selection dependent. When we did our study, we selected patients whom we had identified as having healed their intestine and apparently doing well. And we asked them, are you willing to do a single dose gluten challenge potentially or sham? And that's a group that might not be a group that would necessarily always recruit themselves into a clinical trial, because all you're asking them is to do one potential exposure to gluten. And it's quite likely that many of them had never deliberately done that before. So that's a circumstance. I think perhaps the design of our study significantly increased the possibility of a nocebo response. On the other hand, when we've done clinical trials for patients where we're going to give them a 1, 2, or 3 day or even a 6-week challenge with gluten, usually those patients have to express a willingness to be exposed to that much gluten for that long, whichever duration it is. And so they're going into it with a high expectation they're going to get gluten. So it's possible that some of them will self-select themselves away from participating in that trial if they are really worried about the effects of gluten that they may have. Of course, when you do that in the context of a placebo-controlled trial of a therapeutic, you're layering now on top of that the hoped for placebo effect that the patient's going to have. They won't call it a placebo effect, but the hope for effect benefit they're going to have in protection from their participation in that investigational agent, or taking that investigational agent. So it gets a little bit more complicated. There are run-in strategies for dealing with that. There's patient selection strategies. Again, it depends on the particular group of patients that you are using as participants in your trial and the design. So it is an issue. However, the biologic measure of IL-2 is very specific to gluten in the context of a treated celiac patient. So that, in a way, provides an extra level of security around the certainty of the symptomatic protection.
Okay, great. Well, we'll look forward to the trial design update in the later session. Thank you. I'll jump back in the queue.
Thank you, Andreas. We have one question that came in writing from an anonymous attendee. The question is it easier to reach the lamina propria with a therapeutic agent by way of oral route or intravenous subcutaneous route? Is there good data to support your answer? Maybe one of the KOLs want to take this question.
Well, I can give a short answer in that this depends, of course. This depends, of course, on the substance you're using to treat. So that is, if it's an antibody, which will then be killed by the stomach acid on the one hand, and it's quite large in size to go paracellularly, you certainly are very much better off with subcutaneous or IV route. Yeah? But if it's a small drug that is stable and there is a significant leak on the one hand, or there is an active transport mechanism, an oral route is very feasible.
Thank you. We have another live guest here, which is Matt Kaplan from Leidenberg. Matt, please unmute yourself and go ahead.
Great. Thanks for the presentation and thanks for taking the questions. I guess for Dr. Murray, I guess given the difficulty in diagnosing patients where it could take up to 10 years, how does this difficulty impact running clinical trials and studies in OECD patients or in celiac patients overall, and in terms of stage of the patients that you're getting in the studies and ability to have an impact on their disease?
Okay, so if we look at the delay in diagnosis itself, it often means now you're dealing with patients who are fully adult. They have had symptoms for a long time. And so they're usually delighted to find out their diagnosis. Many of them are not so happy to find out that the treatment is quite a burdensome treatment, that the burden of care is entirely on them. It sometimes can leave patients, I won't want to say medically orphaned, but perhaps not so connected to the healthcare system because they felt betrayed by it or let down by it. That's especially so in America, in the US, specifically the United States, because of the structure of our healthcare system. So often when they're diagnosed, they don't necessarily have a lot of follow-up care. Now, it does mean that the recruitment for trials is often a little bit different, at least as I said in the US, it's often direct to consumer, as it were, or to advocacy groups rather than necessarily going to GI practices and looking for their established patient cohorts. Because unlike diseases like inflammatory bowel disease, where the patients have to maintain an ongoing relationship with their gastroenterologist, that's not the case with celiac disease. So it's different. With regard to recruiting patients with ongoing symptoms, it hasn't been a problem. I mean, we were part of one of the largest celiac action trials, which was the lattoglutenase, and we had no problem recruiting patients, for that trial. There is, as a trialist who spends a lot of my time talking to potential participants, we have a high level of enthusiasm for participating in trials from phase 1 first in human studies all the way to phase 3 studies. So there's a strong interest in the celiac community for participation in trials.
Okay, that's helpful. Thank you. And then for a question for Dr. Schumann, I guess given the what we know about the mechanism of action of 856, how would that have an impact in your hands in the models that you run with respect to impact on barrier function and maybe barrier restoration?
So I'm not sure if I got it acoustically right, but what I understood is the vaccine studies, how would they work on the barrier function? Is that right?
No, in terms of IMU 856 and action. How would they in your hands?
If IMU 856 changes significantly levels of tight junction proteins, including claudin 1 and claudin 2, it has a good chance modifying the barrier in such a way that celiac relevant Leiden peptides are reaching the lamina propria at lower levels, and thus there might be less induction of disease. That would be the hypothesis.
All right. Well, thanks for taking the questions.
Thank you, Matt. And we have one more in the queue, William Wood from B. Riley. William, please unmute yourself and go ahead.
Hi, thank you. This is William from B. Riley on for Montani. I'm just trying to walk through if you've done any preclinical studies. I believe there's at least one mouse model with your 856, and then looking at IL-2 regulation after the fact?
So actually, so far we haven't done any gluten challenge in mice, actually. So it was all on the DSS colitis.
Okay, thank you. And then a quick follow-up, and you may actually get to this in the second part. You've obviously touched on a lot about IL-2 being a key biomarker in celiac disease, and I was wondering if you've had any conversations with the FDA that may suggest that they'd be amenable or amicable to the approval on an IL-2 biomarker, or either at some point, I guess, in the future.
Yeah, so this is Andreas here. I think the guidelines are very clear that they actually allow IL-2 in combination with gluten challenge for early clinical trials. But as I outlined, I think they're pretty clear on the pivotal studies that the approval should be based on the combination of an objective marker, histology, and also on symptoms. And that's very consistent for the gastrointestinal division of the FDA with other indications. For example, if you look at inflammatory bowel disease and other GI disease, they often ask for the same thing. So I actually think that using IL-2 for approval would not be enough. You have to show, I think, effect on symptoms and histology. And as I also outlined, I think in the current trial results is it also may mislead you sometimes because the gluten challenge, I think, overestimates the effect of gluten on the disease when you actually want to treat a different population of ongoing active celiac disease patients that may or may not have a lot of gluten present, but the inflammation is still sustained for these patients. So I think it may overestimate the effect that gluten has on the OACD patients.
Understood. Thank you so much.
All right. Thank you, Will.
Thank you, William. For time reasons, I know we still have a couple of questions that came in writing, but we are happy to answer these later on or after the webcast. For time reasons, we will move on now with the presentation. So back to you, Andreas, for an overview on our IMU 856 development program.
Yeah, thank you. And this, I think, very much, addresses now the questions that I also got in terms of what are we measuring in our phase 1 trial in 856. So let's start with what we have already talked about in terms of the different parts of the phase 1 trial that's ongoing. So this slide summarizes the different parts of our phase 1 trial of IMU 856. The part A, which was the single dose evaluation in healthy human subjects, and the part B, that was the 14-day repeated dose evaluation in healthy human subjects, have been completed, and we also have reported this in last year. So currently the part C, the 28-day repeated dose evaluation in celiac disease patient is ongoing, and results are expected to be reported in mid-2023. Just quickly summarize the results from the phase 1 study, again, the parts A and B. So the pharmacokinetic properties were found to be dose linear, meaning that, for example, if you have a doubling in doses, leads to a doubling in exposure, which I think is something that's very much hoped for. The plasma half-life of IMU 856 was found to be around 20 hours, which really makes this once daily dosing feasible. And the accumulation factor for repeat dosing is quite low, which allows therapeutic trough levels to be very predictable, but also be reached quickly. So this last point here on the trough levels highlighted in this slide. We have stable trough levels that are reached within 4 to 7 days after the start of the once daily treatment. And these trough levels also fall quite rapidly following the cessation of the treatment, which also is, I think, desirable for a treatment. And this pharmacokinetic profile of IMU 856 is simple and makes use of IMU 856 very pragmatic. This slide summarizes the adverse event rate observed in repeat dosing of IMU 856. There was no dose dependency in the overall rates of adverse events. There was also no drug-related serious adverse event that were observed with IMU 856. So this slide lists the most common adverse events for repeated dosing of IMU-856. Once daily dosing was found to be safe and well tolerated. With headache and catheter sign pain, please note this is an oral drug. Yes, so this is really our catheter where we use for blood sampling, being the most common treatment emergent adverse events. We did not observe any systemic laboratory changes following IMU-856. In particular, there were no Hy's law cases that would potentially indicate an hepatotoxic potential. I'm going through because I think this is all published before in much more detail. In summary, IMU-856 was found to have a favorable safety and tolerability profile, and doses up to 160 milligram IMU-856 once daily were evaluated, and no maximum tolerated dose was reached. And the pharmacokinetic profile was found to be supportive for once daily dosing. So let's go into, I think, what was asked before, what to expect from our ongoing Part C of this trial. The Part C includes patients with well-controlled celiac disease adhering to a gluten-free diet in a gluten challenge study design. We have a treatment period of a total of 28 days that we dosed either with 80 or 160 milligrams of IMU-856 or placebo. This treatment period is divided into a 13-day treatment period, which allows for IMU-856 to potentially provide if its effects on the bowel barrier function to be established, and a subsequent 15-day gluten challenge period that we do with 6 grams of gluten daily. The study has histologically assessments at baseline after 28 days of treatment. And most importantly, on the first day of gluten challenge, the IL-2 response in blood plasma will be measured. So this slide lists the main inclusion-exclusion criteria for the celiac disease population. And although the Part C, of course, primarily focuses to evaluate safety and tolerability during 28 days of dosing in celiac disease patients, the biomarker outcomes highlighted in the previous slide in terms of histology and also IL-2 are also complemented by patient diaries related to characteristic celiac disease symptoms, scores related to the physical and social activity, as well as the quality of life. So we have both the biomarker that were mentioned, IL-2, gastro and histology, as well as we correlated to symptoms and basically quality of life measures, symptomatic measures. And we're very much looking forward to share with you the results of the Part C in celiac disease patients in mid of this year.
Thank you, Andreas. This brings us to our second question and answer session with the Immunic team. Once again, please use the raise hand function of the Zoom portal to queue your question or submit your question in writing. And we received one question in writing. Would you expect IMU-856 to be prescription or over the counter?
So definitely this is would be a prescription drug. It's regulated as a pharmaceutical. As a prescription pharmaceutical, yes.
Thank you, Andreas. And we once again have the other Andreas in the queue from Wedbush. Please unmute yourself and go ahead.
Thanks for the follow-up, taking the follow-up question. So to my earlier question, to what extent has the Part C portion taken into account potential nocebo effects? What has been taken to kind of limit that?
So I think what Joe Murray has really showed was that the symptoms could be a nocebo effect if patients have certain expectations in this trial. So this is, I think here you have a placebo-controlled trial. That means there is a lot of uncertainty, and that was also, I think, Joe Murray, outlined. There's a lot more uncertainty of what to expect for these patients. So, and I think in that respect, I think the design is a little bit different, so that you, even on the symptoms, I think probably don't have the nocebo effect that Joe talked about. On top of it, of course, Joe had shown very good data that the IL-2, for example, is very independent, it's very objective. Yeah, so you can you can maybe get symptoms because you expect certain things, or you think you get symptoms because you expect something, but the IL-2 response was completely objective as compared to symptoms. And I think we wanted to use here this webcast as well to, I think, use this time to really highlight the importance of IL-2 for our Part C as well. IL-2 will be the most important outcome of this trial because it's objective. We will correlate IL-2, of course, if we see an effect there with changes in physical activity, in symptoms, in quality of life outcomes. I think this must be supported by a change in the IL-2 primarily. I think that's really the expectation that we have, that the IL-2 response on the first day of gluten is the primary outcome of the study. And I think this is in line, I think, with what Joe had presented here in terms of the potential nocebo effect if patients have certain expectations in a trial.
Maybe to add something, Andreas, to this. We try to really learn from the good trials performed in the recent past and the challenge trials, and we are very happy that we have Bob Anderson as principal investigator in this trial. And you've seen some of his work he has done in the past, also in the presentation earlier today. I think we try to reflect what is known today in the design of the study, and I think it's quite good design for this early proof of concept for IMU-856.
And just a quick follow-up on the time frame here. So 28 days, is it likely, I mean, maybe Dr. Murray can also comment, but is it, more, is the nocebo effect more prominent in, early on in 28 days? And then when you look at the potential registrational trial at 52 weeks, a lot more mitigated? Thank you.
Yeah, I think, and I've shown this with the successful gluten challenge trials that I showed in this presentation early on, where we had like 2 candidates had a 6-week gluten challenge trial that really showed good effects of preventing the histological changes. And I think we were restricted, of course, with this phase 1 trial to a 28-day period because of the early phase here of the development. So we try to, I think, make sure that we can get as much as possible out of this trial. And that's why we have chosen this design that basically has a 15-day gluten challenge. For the IL-2 response, this is a very acute response, actually the most prominent on the first day of gluten challenge. So here the first day, so the day 14, is actually the most important readout, because this is when you have the most prominent gluten challenge on the first day, when these patients that are well controlled with their gluten-free diet, where they have the IL-2 response. I think for other outcomes, I think for, and I think Joe Murray, highlighted it as well, that the symptomatic response also is quite immediate. So I think there the outcome, I think you can see in this trial, the histological response or the histological prevention, I think it will probably with 2 weeks a little bit short for that, and that was highlighted with the 6-week study that I think usually is done to go at the prevention of histological damage. So, but I think we hope to see a first hint, hopefully there as well. So I think that's the expectation for the outcome. And again, I think the expectation also is that, and we discussed this with Bob Anderson there as well, that the nocebo response here is really not applicable to this trial design, because we have a placebo-controlled trial that's randomized, and the expectations of the patients are not that high that you have or have not symptomatic response on the first day of gluten challenge. And so I think that's probably may not be the symptomatic response may not be influenced by the nocebo response here in our trial. But again, we always have the IL-2 response that's quite objective, and so we can relate this to.
Great, thank you. And thank you for this presentation.
Yeah, thank you, Andreas, for
Thank
the
you.
questions.
Maybe one follow-up question here from the audience. What % reduction of the IL-2 response to the gluten challenge are you hoping to demonstrate on drug in part C? What would be the bar to take this molecule forward?
So I think this is a difficult question because there's no established threshold for this. Yeah? And the reason is really that the gluten challenge studies have had different inclusion-exclusion criteria, what you consider well-controlled patients, and how you exclude patients that have ongoing active disease. The gluten challenge study also have been done with different doses of gluten, and this really had a little bit to do, I think, with the period of gluten challenge that some of the gluten challenge studies have done. For example, I mentioned the 2 6-week gluten challenge study. They only use 3 grams of gluten because I think it's hard to sustain a higher dose over a longer period of time. Yes, because these patients will develop symptoms that develop problems during the gluten challenge. We have chosen a 6-gram gluten challenge daily, which allows probably for a different amplitude of the IL-2 as compared to a 3-gram challenge. So I think, and you have also seen in the immune tolerance study that it was really also a question not only of the threshold in terms of that on average you have to achieve like a 30 or 50% decrease in your IL-2 response, but also how many patients basically had an absence of the IL-2 response in placebo and in the treatment group. So it's probably not a hard criterion here, but I think we hope that, of course, that discussion or that consideration is mute when you see the data, because it's such a clear difference that we don't have to discuss this and create criteria that will explain our results. So I think that's but there's no hard criteria that are well established and accepted, unfortunately.
Yeah, Dr. Murray, I still see you on the line. Maybe there's one more question for you. I hope you can still hear us.
Yeah, go ahead.
Yeah, perfect. What biomarkers have the best correlation with patient-reported outcome and/or symptom assessment measures in celiac disease? Any good meta-analysis to support this?
Okay, it's an excellent question. So I would say no, there isn't any good meta-analysis to support what we've seen. So far, there have been a number of studies that have used histology, for example. And we know that quantitative histology will respond in both directions. It will get worse with a gluten challenge, though probably either higher dose for 2 weeks than what we're using here, or though there may be a signal, even with 2 weeks at 6 grams a day, but often over longer periods of time, like 6 weeks would be fairly typical to see a worsening. And what you're looking for there is protection from worsening. And so there does seem to be some, that seems to be reproducible. For serology, standard serology testing, not so helpful because the kinetics of that response are quite delayed in terms of a challenge. When it comes to responding, or we call a D-challenge, or you take patients with active disease and you want to treat the active disease, there you do deal with what I call the Hawthorne effect, or the in-study effect, is that most patients in that setting will improve as you put them into a study to some degree, and patient selection is absolutely key to I believe, to ensure that you're getting the right patients. Those are the patients who perhaps will not respond so highly to simply a placebo interaction or the in-study effect. But we don't have, other than histology is probably the hard. That's why I think the FDA has emphasized histologic outcome measures in some therapeutic, at least registration trials, as an important part to that. We do have, so when we compare any of these objective testing with symptomatic responses, they're not quite so clear. The single dose challenge or the multi-dose challenge where you deal with the nocebo response, there seems to be a correlation between IL-2 and the degree of IL-2 change and the timing, particularly the timing of IL-2 change and the timing of onset of symptoms, but nothing that raises to the level of evidence of a meta-analysis.
Great, thank you very much, Joe. This concludes our second question and answer session. I would like to turn the webcast back over to Daniel for any closing remarks.
Yeah, and at the end of this R&D day, I would like to thank you very much for listening to this call. Seen a lot of people attended the call. My special thanks go to our two speakers, Dr. Murray and Dr. Schumann. We are honored to have you here on the call with us today. Thank you so much. Thanks to everybody for the lively discussion here and the encouraging questions. And some of the questions still are open, and we will try to follow up on that individually. Let me allow at the end of the presentation to summarize shortly 856, the molecule which has the potential to be the new innovative approach for treating GI disorders, in particular celiac disease. The compound has shown already favorable safety, tolerability, and pharmacokinetic profile in the single and multiple ascending dose portion of the phase 1 clinical trial. And currently, and that's the exciting part, we are still testing patients with celiac disease, setting the stage for potential first-in-class oral celiac disease therapy. IMU-856 may offer extensive potential beyond celiac disease as well because of its mode of action on the barrier function. Finally, I would like to thank my colleagues at Immunic. It's great to feel the enthusiasm here in the team. And I hope we are able to reap the fruits of the long intensive work in the near future, mid of the year when we read out, hopefully good data from part C of this trial. And with this, I wish you a wonderful remaining day.
Thank you for joining Immunic Celiac Disease R&D Webcast today. The event has now concluded. You may now disconnect.